Okay, I make it 9:30. Welcome everybody to this board meeting held in public. A particular welcome, well, normally at this point I say a particular welcome to members of the public. I think on this occasion, unusually, we've only got one, and that's Alison Moore, who writes for HSJ. So I can make a personal welcome to you, Alison. Nice to have you with us. Just a reminder to everybody that we'll be recording the meeting, and that the recording will be put onto the Trust website. Just before I get to apologies, I wanted to start the meeting with a bit of sad news. After a long period of ill health, I'm very sad to announce that Lynette Wells, our Director of Corporate Affairs, has decided to take early retirement. Everybody on this call will know that Lynette's worked for the Trust for a decade. She's been responsible for Trust Board, corporate governance, legal, comms, and hers was the kind of role that was a bit below the radar, and a lot of the work that she did was behind the scenes and made a huge difference overall to the Trust. She's going to be hugely missed across the organisation. People turn to her for her knowledge and wisdom, and also kindness and compassion, and she helped anybody who asked for it. I know how much respect and admiration Joe has for Lynette, as did Adrian, Joe's predecessor. As far as I know, I think Lynette supported 3 generations of board chairs. I know how much David, my predecessor, valued Lynette's contribution, and I spoke recently to David's predecessor, Stuart, who also was full of praise for the work that Lynette did. So although she won't be she won't be on the team, I know that she'll be cheering us on from the stands while she continues her convalescence, and she'll be missed, and we wish her well. So on that note, let's move to apologies. We're somewhat depleted this morning. We've got apologies from Karen, from Paresh, and Miranda, who's with us now, will be dropping off the call later in the morning. I wanted to move to the Hero of the Month awards, and you can see the 2 nominations that are there in front of you. One of the joys of my job is that I get to meet and spend a bit of time with all of the heroes, and it's one of the best bits of my job, I have to say. I had a very insightful and frank conversation with Mark in my office, which was very much appreciated. Enjoyed that, and had a good time with the community nursing team at Wheel Farm in Westfield on a beautiful sunny day, thanking them for all of the hard work they did in the storms and the wind and the rain, and so really enjoyed that, and a big thank you to all of the winners. So the declarations of interest, we've had none, so I will move to the minutes and ask if you are happy for me to approve the minutes. Vicky.
Thanks, Joe. Just a point of clarity. So on page 14, we talked about birth rate plus and maternity establishments. So it was actually about an increase in the uplift. So the establishments do have an uplift or a headroom for training. So just important to make that distinction. And similarly, in the F&I committee minutes, it was about an increase in the uplift. Thank you.
Great. Thanks, Vicky. Jackie.
There's just a couple of typos which just make the sentence not work well. It's on page 5, the penultimate paragraph just needs, the first sentence just needs to be reordered. and much further down on page 9, the last paragraph, it's the implantation of eConsult that worries me. I don't want anything implanted, so implementation. Other than that, fine, thank you.
Thanks, Jackie. So with those clarifications, everybody happy that I sign those as a correct record? Thank you. There are 2 matters arising. Both have been completed. So unless the individuals who are involved want to add anything, I was going to just move on beyond that. Thank you. So to the board committees and to feedback. Can I start with F&I, Nikki?
Sure, I'll take the paper as read, Steve. I think the only thing I wanted to say was just to thank the ESHT and the ICS teams for working collaboratively in an attempt to balance the finance with the delivery of services. I was going to say a bit more, but I think I'll stop, otherwise I'll just cough at people. But if people have questions, please shout.
Thanks, Nikki. And any points anybody wants to pick up with Nikki or anybody else who might be able to speak for her, perhaps? No. Okay. Let's move to pod. Caris.
Yeah, after a very previous pod being very sombre, it was good in terms of the May update to hear some green shoots, Steve, especially in terms of our absence record with staff suffering with COVID. That was very positive, but we remain cautious, and it was very reassuring to hear at pod committee how cautious the exec is being, and the focus remains on delivering the strategy. As a pod committee, we've been very pleased actually with the pace in terms of not only the HR team, but collaboratively with the rest of the service in terms of delivery. It was also great to hear in terms of some of the BAU activity, how we're not becoming complacent. So for example, in terms of time to hire, we've made some great strides forward, and yet the team is still focused on what more they can do. And I do want to thank Steve and the team really for that culture they've created within the team.
Brilliant. Thanks, Caris. Any questions for Caris or indeed for Steve on that? No? Okay. Thank you. Quality and safety, Amanda.
Thank you, Steve. You've got the report in front of you, so I don't intend to go through it. As you could see from the report, it was quite a full and compact agenda. We looked at some of the key areas that were just causing us a slight bit of anxiety in terms of changing dynamics. So the red flags on safer staffing and just the falls and a few areas. So we've asked for further deep dives into that. We had a fantastic presentation from the urgent care team, which really brought to life the urgent care experience and the great work that's going on. And whilst there are issues in terms of staffing, etc., it was really refreshing to see that brought to life. We are going to have a deep dive into maternity at our next Quality and Safety Committee, which I think is quite important for this board, given all that is going on in terms of maternity. And we are keeping an eye in terms of our CQC compliance in all areas and doing some deep dives into service areas as well, so that we're making sure that we've got oversight of that. So other than that, I think that's all I'd like to highlight. Vicky, is there anything you'd like to contribute?
No, thanks, Amanda. Covered it all.
Thanks, Amanda. Questions from anyone? No. Great. That sounds like really good stuff. Strategy, Jackie?
Thank you. Again, as the others, I'll take the paper as read. The committee met in February, and it's fair to say things are moving at pace in terms of ICS. So we saw some high-level thoughts from the ICS, and then I suppose the question for us is we have a strategy, and so how does our strategy best align to that that's emerging from ICS, so that we make sure that there is good dovetailing. I think at a system level, there's obviously a wish to tackle everything, and I think how that applied to us is which of those elements are priorities for us, and then therefore we might need to sort of embed more in certain key areas like mental health, for instance. MSK was an update on how what's happened with the change in terms of bringing the two services together, and therefore the strategy is to align the service so that there is equitable access across the patch. There's quite a lot to do there, and that will follow. But first off is we need to align the access. On health inequalities, we're really pleased to see that we've got a chair leading on this, and that how therefore we, as place, address the health inequalities that are pertinent to us, and that will feed down to the divisions. And then the last point was cardiac and ophthalmology, just noting the process and adherence to the current timetable, so therefore expecting a decision in around about August. I'm happy to take any questions.
Lovely. Thank you, Jackie. Anything from colleagues? I've got a hand up, but I can't quite see whose it is. Hold on.
It's Joe, Steve.
Oh, Joe. Apologies, Joe. I've got you now.
That's all right. It's probably a comment rather than a question. Just because it's a recent update. So the in the MSK, there is a Sussex-wide piece of work to standardise the MSK model across the whole of Sussex. And then in due course there will be a discussion around commissioning and a way forward for that. So that will come to Stratcom at a future meeting and talk through that model. Hopefully not this one, Jackie, then the next one.
Okay.
Just things progressing, as you say, at pace at the moment.
It is so fast, isn't it? You write this up, and February just seems like forever ago now.
Yeah.
Okay, thanks, Jackie. I don't know about others. I was getting some feedback on the system. Then everybody could just turn their mics off if they're not speaking. I don't know if that will make a difference, but let's hope it does. We haven't got a paper on audit this time because I think the meeting is next week. Paresh, who's not very well today, said that, Damien, you might, if there was anything you could give us a quick update. I don't know if he told you he was going to say that to me, but if there is anything to say, Damien, now would be the time.
Yes, thank you, Steve. So the point is that we didn't meet this month because we're timing it to fit with year-end accounts. So our sign-off is on Monday, as you said.
Okay, that's good. So we'll hear all about that next time. So thank you for all of those reports. Just before I move to item 6 and Joe's chief exec report, I meant to say at the beginning that agenda item 8 around COVID-19 restrictions, the paper I think we are withdrawing. I'm just looking at Vicky and Joe that for nods that that's the case, on the basis that as the paper was produced, new guidance arrived. So so colleagues are looking again at the detail of that. And I guess if there is anything that you wanted to say about the new guidance, I guess you could pick that up in another place. Joe, is that?
I was just going to say, so I agree pulling the paper, but Vicky has got something prepared just to talk through because we've done the work already. Well, I say we, to be fair, David and Vicky have done the work already to assess the new guidance, so we can give a more up-to-date, but it'll be a verbal update.
Okay, that's perfect. Excellent, thank you. Okay, well, on that basis, then let's pass over to you, Joe, and you're going to give us your report and take us into the IPR as part of the same process. So over to you, Joe.
Thank you. So first report is my update, which I'll take as read, but I just want to draw a few things out. So again, I want to thank all of our staff. They've been remarkable over the last couple of years, but they continue to be absolutely remarkable, and I'm really proud of them. They're still being innovative, they're caring, and they're putting their patients and the service first. And I think the important thing that we keep reiterating as an executive team, and I know as a board, is that it's our responsibility to look after our staff, to let them look after our patients. So I just wanted to draw that out. It has continued to be really busy. We've had bank holidays, we've had jubilees, which has been absolutely great, and we've done a few things to celebrate that with our staff. And somewhere are the pictures of the queues outside the ice cream van, which actually was great, and people had and it wasn't raining. So that was brilliant. Just little bits that I think make a big difference to people whilst we're in bed, sort of wider work things with wider workforce support. The business plan is on the agenda. We'll cover that in a little bit more detail. It's just to say that it's still a work in progress. What we're trying to do this year, slightly differently than we've done before, is to be really clear about what our priorities are as an organisation, and let's be realistic. They still need to be in line with NHS objectives. However, it's being really clear to the rest of the organisation that these are what our priorities are. And as always, there's still a little bit of work to go through, but we'll pick that up a bit later. We've talked about it before, but just for absolute clarity, our priorities are workforce and wellbeing, maintaining our quality of care, at least, if not improving, but Vicky will talk about where we are on that. Increasing our elective activity to make sure we've got at least 104%. Because that impacts on our financial position, as well as obviously the care that we give to our patients. Delivery of our financial plan, not quite finalised yet, as the final submission's not due for another week or two. Reducing the number of patients that now can be managed in a more appropriate setting, so whether we call them MRDs or NCTRs. It's patients that can be managed or supported elsewhere. And then obviously to make sure we continue to provide safe and sustainable urgent care. This will come up a bit later, as we've just hinted at. We are now learning to live with COVID, and Vicky will talk about infection control rather than, and we've got to move away from COVID. That said, we have seen some increase in numbers, so I almost don't want to say it out loud. Managing patient flow, Tara will pick this up in more detail. There's a number of initiatives that have gone in that Tara's talked about that we were going to implement, or we have now implemented. It continues to be one of our priorities, as I've just mentioned. Cybersecurity week, we have to remember that there are other things other than just the elements of delivering direct care, and we still need to make sure our organisation and our information is safe as well. I think we've seen elsewhere when systems go down, it does have an impact. So we were celebrating Cybersecurity Week. Staff car parking, we remember that we took the decision some time back, and I know I reported this last 2 months ago. We're still not reintroducing the car parking fees. We felt that that was the right thing to do for our staff. We are obliged, however, to make sure that we have got we've got some controls in place around the numbers of people on site and where people are parking, so that they're safely parking. So we are putting a permit in place, and that's being introduced as we speak. And a big thank you absolutely to everybody, but to Chris's team, who went quietly working away in the background to make sure we've got a safe environment for our patients and our staff. And there's a number of refurbishments and other things that have been happening over the last couple of months. It's been a really busy time the last couple of years for our estates colleagues. I just wanted to recognise them. So I'm going to keep going, if that's okay, and go into the first page of the, actually, Steve, do you want me to pause and see if there's any questions on that, or do you want me to go into the IPR?
Let's just see if there are any questions on that. Amanda. You're on mute, Amanda.
Oh, I would have to do that. I was just asking, Joe, how we're celebrating cybersecurity this week. What are we doing to mark it? Because, as you quite rightly say, it's one of those things that is so important to our safety and security, and yet we don't often talk about it. So it's a great chance to do so.
So Damien may want to come in. It happened in May. So it was a number of things around raising awareness, and a sort of campaigns around that. So it's more around best practice and awareness. But can I just bring Damien again, because he'll be able to talk about it in more detail than I have.
So yes, we went through the process of cybersecurity. We are actually getting ready for our DSPT registration annual approval, which we'll go through next month. There are a few things we would like to do, particularly around getting even better than where we are right now. So that's around being clear about patching updates. And actually, there will be a process that I will work with Tara to try to get this into a more regularized process. But I think your point is totally valid. I think the scale of work that the digital team have been doing is sort of unnoticed. So perhaps we need to think about how we recognise the scale of work they do. In particular, given Joe's point about last week, where we actually had a challenge to our digital platform, and actually the scale of work they put behind the scenes is huge.
Thanks, Damien. Miranda.
Thank you. Joe, thank you for listing out the priorities. One thing that occurred to me while I was listening to you is, given that we now have the ICB, should that be reflected anywhere in our priorities, or is it covered within each one, or is it implicit, or what do you think? Is it worth reflecting that?
So we have in the past, so last year, one of our priorities was to make sure that we engaged at place and at system level. We are very much still in that place, and we, as you know, we work on a very integrated basis with a local authority. So I haven't listed it as a priority because I think it's implicit in what we do. It probably will feature in the more detailed plans when we finalise the business plan. We are aligned, and our strategy, if you recall, is aligned back to the ICS Vision 2025. The ICB will be writing its new strategy over the next 6 months, so by December, and then we'll have implementation plans by the end of March. But as we stand, they are aligned. But I just haven't put it as a priority because, well, because it's implicit. But we can draw that out in the business plan if that's something that people feel we want to do.
Thank you.
And Jackie.
Recognising that it's very early days, is there any initial thoughts on how the e-consult at the front door is going? And I'd just be interested, because it's been so busy, people coming in or trying to come in. I've just wondered how that's gone, how it's gone down since it started.
But bring Tara in.
Tara, yeah.
Yeah, I think it's very difficult to judge, but what we've seen is patients being checked in very quickly, and also patients being supported to be redirected to appropriate services. And we are seeing a significant increase in our utilisation of the UTC. Okay. So that actually helps support the delivery of our front door. So with regards to success rates, we will look at how we can get feedback from patients, but at the moment our care navigators that are at the front supporting the patients have not fed back any negative response. And it is allowing, as I say, our patients to be checked in more quickly and more effectively.
Okay, thank you. And just on a bit of feedback, I was given feedback from someone from another trust who used the Conquest UTC, and they commented how excellent the staff were. Although it was busy, it didn't feel that way, and it looked like it was being really well run. So pass that on. Thank you. I will take that back to the teams. That means a lot. Thank you.
Always good to hear that. Thanks, Jackie. So Joe, back to you then, and IPR.
Thank you. So just moving on to the overarching IPR document. So just to draw out a couple of areas that I'm really proud of, and some areas that still need some focus, whether that's because as an organisation, but actually a lot of this is as a system and nationally in some cases. So things that we're really proud of at the moment, we have we're in the top quartile nationally for our 62-day performance. That does not mean that we are where we want to be, so I do want to stress that, but Tara will pick up around the number of referrals and some of the actions associated with that and where we are against our more detailed plans. We continue to not have any patients over 78 weeks, and we are ahead of our trajectory for patients over 52 weeks. We have seen an increase in those patients numbers, but we were expecting that because of the shape of our waiting list. But again, Tara will come back to that in a minute. CapEx spend, that's been incredibly hard work this year, as it was in previous years, and we've delivered our plan as expected to do. So to be fair, thank you very much to actually all of the execs, because it does take everybody's effort to make that happen, but just particular thank you to Chris and Andy Bissenden as well from a digital perspective. It's their teams that bring this to fruition, really. Vacancy rate has dropped, and for the 5th consecutive month, so again, well done to Steve and his team as well. And the emergency department saw an improvement, and particularly in relation to ambulance handover delays, but again, Tara will pick some of that up in more detail. The reality, however, it's really tough at the moment, and we are, even with setting the priorities, we're obviously trying to ensure we do well against our urgent care standards, as well as the delivery and recovery of our elective. So our actual 4-hour performance has been declining over the last couple of months. We've always been, or well, not always, in recent years, we've always sort of been a top quartile, top third provider, and that has slipped down. We're still in the sort of, well, we're still well within the top 50%, but we're not where we would want to be as an organisation. Tara will talk a little bit more about it. There are a number of actions that are going in place, and we've seen some good performance days. However, we just need that to be consistent every day. That said, and just to pick out Jackie's feedback, we speak to members of the public on a regular basis in different forums, and actually there's nothing but praise in those forums, our individual feedback as well. So whilst it is incredibly busy, partly affected by patient flow, as long as patients are getting as good of experience as we can, and obviously we're worried from a staff perspective as well. Jackie, do you want me to just pause on that bit?
I'm just thinking, is this the new normal, that people just choose to come to A&E and it's up to us to redirect? Because it just seems now to be consistent, and people seem to be making the choice not to go or have trouble accessing primary care and come to us instead. So should we just be assuming this is the new normal? So
I know we've talked about this a number of times. I think it is the new normal. I've asked the question to primary care, and they are, and I know there's feedback. Can't switch anything else off. So I think primary care is seeing an increase in activity as well. Tara has talked about and will continue to talk about alternatives and redirecting at the front door, so I won't steal her thunder on that bit. We are going to have an urgent care summit in East Sussex, which I'm going to chair in a few weeks' time, bringing together primary care, local authority, mental health, and ourselves, obviously, as acute and community, to see what else we can do. But the reality is, I think the public's tolerance, if you like, to waiting is different, but there is also they are struggling to access or perceived access to other services. But we have got a lot in place, and I think it's about how we use the resources to the best of our ability. And Tara is well used to me saying, make sure we've got the UTC functioning to the best of its ability, make sure we've got capacity in there, because it really is the key factor. It's not the only factor, which I'll come on to in a minute. It really is a key factor in being able to release the emergency department staff for seeing the sicker patients. But you're right, Jackie, I am of the view we can redirect as much as we can, but we will need to be able to put capacity in or redirect at the front door, but that's part of what we're doing.
Thanks, Jo. Amanda.
Jo, just picking up on that point, and it's great to hear that there's going to be a summit with professionals, because I think you've talked before about redesigning the urgent care, and we're certainly doing a huge amount in that space. I just wondered if there has been any kind of consultation discussions with our patients and our population around this, because it has changed dramatically, hasn't it? Things have been challenged during COVID, and we're now about to reset. So I just wondered what engagement with patients and the public there had been.
So there was a review done mid-COVID, if I can put whenever mid-COVID was, but there was a report done asking people how and why they were accessing urgent care. We've done that before as a East Sussex system, so there weren't any surprises in there. I think you've got perceptions and reality, people not necessarily understanding all the alternatives. So we may, and it's a good question, Amanda, it may be that once we've had the summit, we do another piece of work with the public to be able to ask this question. I think we know what the answers are to those. The question is what's the solutions, rather than, and we know the why, it's the what are we going to do differently element. So thank you for that. That's a really good reminder. There may be some other questions, but Tara will cover some of those. Just quickly to move through. So discharge, again, I know Tara's going to talk through some of the solutions to that. It remains incredibly hard to get patients out of hospital in a timely way. I do see, you know, the impact of that from a flow perspective, an urgent care perspective, a patient experience perspective, from their relations as well. And we have got, it is one of our, that's why we've made it one of our main priorities. But again, I'll let Tara talk through that a little bit, because there's a lot of system working on that. We're still working through and finalising our budgets with the ICS, or what will be the ICB at the moment. So Damien will pick that up in the finance section. But it was a challenging first month, and that was primarily due to it being April, bank holidays, and still having COVID in place, which was affecting some of our elective capacity. But we've got that back on schedule now. And the other thing, just to pick up on workforce, so you will see some of the workforce metrics again. I know Steve's a little bit poorly, so I don't want to steal his thunder, but just to say we've got a real focus at the moment on trying to align what we're spending on our finance, on our workforce, versus the availability of workforce in our clinical settings. I'm sure it'll come up, is around our supernumerary staff, because we have got staff that don't appear on rotas, but they are in the trust, albeit they're in a supernumerary and a development element. But I'm sure Vicky and or Steve will pick that up a little bit later. So those are the areas we're focusing on. It is a lot, and that's why we've got to be able to drill down to some priorities, whilst we still continue to do some of our strategic work as well. So I'm going to pause. I would suggest that I let colleagues carry on, and then the questions can come in, because there'll be some more detailed questions, I'm sure.
Yeah, thanks, Jo. Yes, I agree with that. Let's move straight to Vicky.
Thanks, Chair. So, as Jo said, it's been another incredibly busy 2 months since the board last met, and my thanks, as always, to all of our amazing staff who continue to work incredibly hard and often in very challenging circumstances to provide the best possible care for the people that we serve. I have made some changes to some of the data in the pack. I hope that's helpful, and as always, I'm very happy to take suggestions, and myself and David at the end, very happy to take questions. Just before I go through that, just want to say that it was Carers Week last week, and I just want to pay tribute to all of the non-paid carers and the incredible work that they do, and especially our young carers. And I have a personal interest in that, so my thanks to all of them. With regard to incidents reported, both March and April saw an increase. As a result of that, I asked for a rapid review, and that's included an urgent review of the May data. There was a slight decrease in the number of incidents reported in May, albeit sadly the rate of falls remained the same. For comparison, in April of the 962 ESHT incidents, there were 21 moderate and 3 major incidents. And in May of the 942 incidents for ESHT, there were 19 moderate and 1 major. So some reassurance there about our good reporting culture and the vast majority of incidents being of low or no harm. I have undertaken a rapid review and I'm keen to take that to the Quality Committee, so I'll speak to Amanda about how we can accommodate that. But just some themes from the deep dive. We looked into falls, also medication incidents and pressure damage. And we have a considerable breakdown in that. Some of the themes from the falls deep dive, a high number of unwitnessed falls, very high numbers of confused mobile patients, some patients who had more than one fall, and some of our largest areas, the Bexhill Irvine units, our stroke areas and the acute medical unit, really having very frail, very vulnerable, complex patients. And as Joe's already alluded to, we know that we have very large numbers of stranded patients, many of whom are vulnerable and at risk of falls and pressure damage. So really we feel that there has been a very particular case mix of patients over the last couple of months. I have included just as an example incidents for the assessment unit in April by time band, and as part of our ongoing work at falls, we pay close attention to location of falls and time of falls to see if there's any further work that we can do. I think with regard to falls, it's fair to say that in March and April, when workforce was particularly challenged, as we've said, that some of those areas had requested some additional staff for enhanced observation, but sadly that wasn't always possible. So likely that that has at times contributed. In terms of medication incidents, of the 113 reported in April, 82 of those were in our inpatient areas, with others elsewhere in the emergency departments, some in outpatients and some in patients' own homes. And of the 35 incidents on the acute medical unit, the vast majority of those relating to prescribing. So we're continuing there with our colleagues in pharmacy and the medical teams. With regards to pressure damage, April saw 63 Category 2 reports, 35 of those in ESHT inpatient beds and 28 elsewhere, so 19 in patients' own homes and 9 in residential care. As I've said, in April, we did continue to see large numbers of very frail, highly vulnerable patients, many of whom are often non-concordant with care and or resistant to care. In terms of patient feedback, there has been a very slow climb in complaints. However, of the 48 complaints logged for April, 7 of those related to care 6 months previously, and another 5 related to care over 12 months ago. So a notable number of historical complaints, if you like. In April, the Trust did move to the new mandated national system of coding to support submissions to NHS Digital, and that's the Hospital and Community Health Services Complaints Collection, referred to as KO41A. It's a nice, easy title. There aren't any hotspots to note, and although the response times have unfortunately struggled again, largely FFT feedback is very positive overall, and our positive recommendation rates still remain higher than the national averages, which is really encouraging to see. The ED leadership team are working hard to try and improve the number of friends and family test surveys, but as we know, they still remain incredibly busy over the last few months. In terms of nursing and midwifery workforce, I know Steve will talk about this more widely, and Tara will talk more about activity and capacity. Thankfully, April did see an improvement in fill rates and care hours per patient day, noting that there are and were some areas that were still lower than we would like, with the full breakdown, as Amanda said, now discussed at the Quality Committee. Rye is particularly challenged due to location, cost of accommodation, and some transport challenges. Recent recruitment, I'm glad to say, has been successful, but there are still some vacancies there, and the senior team are working with Steve's team to do all they can. Overall, I would say that in recent months, some of our key quality metrics have shown some impact, I think because of the continued demand on the workforce, with significant additional capacity open over the last few months. And as we've said, large numbers of frail and heavy dependent patients. But as always, my thanks to our staff for their continued commitment to provide the best possible care for our patients. Steve, I'm happy to stop there and take any questions before I hand over to David to talk about mortality.
Yeah, thanks, Vicky. Let's open that up for questions. Jackie first, then Nikki.
Thanks, Nick. Thanks, Vicky. I just wondered, were you drawing a correlation between staffing numbers and falls, which would seem obvious to me? And if so, does that then, once we've reached an imbalance, do we red flag it or something? Do we do something different?
So I think, I'm getting feedback, sorry. So Jackie, I think the answer is yes, but not always. So when we spoke to the teams in the stroke wards, for example, they didn't feel that the higher number of falls was specifically related to staffing challenges. They had a higher than usual number. So typically across both of the stroke wards, they would see possibly one fall in a month, but they had 8. And they feel that that was quite specific to the kind of patients that they have had in recent months who were particularly mobile but confused. So quite a different case mix. I think in other areas, yes, particularly at Rye. So Bexhill have been supporting colleagues at Rye, and we did see a larger number of falls than we would normally see in Bexhill. So we've specifically looked into those 19 falls. So I want to bring that deep dive because there's quite a lot of detail in that to the Quality Committee, but I think it is a mix. And I think in March and April, some of those areas had requested some additional staff for enhanced supervision and observation. But I think despite best efforts of TWS and others, given the pressures, it just wasn't always possible. So does that answer your question, Jackie? It's a mix.
Yeah, it's also a worry, isn't it? If we are having people that are more frail and take longer to get out, then maybe our nursing model would be more under threat.
So I think important to reassure the board that, as always, we have several meetings every day with all of the clinical teams to look at staffing, and the divisions are very supportive of each other, and we do redeploy staff, which isn't always popular, and we know that, but we will continue to do that. The nursing establishment review for the wards is now complete and will be coming to the July Finance and Investment Committee, and I suspect we'll have discussion there about skill mix and the case mix of patients and how that has changed. But I look forward to that discussion next month.
Thanks, Jackie. Nikki, does that mean your question was covered?
Yeah, I think so. I think I picked up on a similar thing to Jackie from what Vicky said. And I was just reflecting upon elsewhere in the IPR us saying that our length of stay is going up. And so my concern sitting here was thinking our length of stay is going up. Therefore, I'm anticipating at some point being told that our hopes of closing beds may be pushed out further than we thought. And therefore, are we stretching our staff even further, Vicky? And therefore, is this a concern going forward that we're going to see those same sort of case mix people in our hospital longer? And should I be worried?
So I would say, Tara, I know we'll talk to all of the work that is underway with the rest of the system, and we have managed to close capacity down. Do you need to worry? I don't think so. I would say that staff are working incredibly hard and are absolutely focused on providing the best possible care to patients. But the types of patients that we now are regularly seeing in our beds has changed, Nikki. There's no doubt about that. And I think that is that is true probably nationally. I don't think we would be any different as a system, given all the challenges and Joe has described as a consequence of the pandemic, I suspect. So I think there's probably more discussion for us going forward about what else we can do to support that. But I think staff are providing fantastic care, and although some of our quality indicators have shown an impact in the last couple of months, I think they are largely holding, and that's testament to the staff that are working incredibly hard to maintain that.
Thanks, Vicky. I'm slightly worried about all of the things that Tara's going to come to. I think she's solving just about everything about world peace and the conflict in Ukraine.
With support from myself and David, as always.
I'm sure. Amanda.
Thank you. I think just to reiterate what Vicky has said, the reason for another deep dive, and we did have a deep dive in falls not so long ago, is because the context has changed quite significantly and we need to keep abreast of this context. So there is absolutely no doubt. We focused on last time a really interesting concept, which is a lot of the falls that were being registered were falls that were assisted falls. So they are still falling, but so there is no harm because they're assisted. And of course, if your staffing ratios aren't as tight or robust as you want, that's a kind of risk. So we do need to look at this closely because it is no one thing that is going to answer this question. It's a multitude of things. And so the deep dive into falls plus the urgent care review plus what we're doing is what we need to kind of bring together.
Yeah, thanks, Amanda. Okay, shall we? Thank you for that, Vicky. Shall we move to David?
Thank you, Chair. So if we look at the mortality page, the shimmy and the RAMI both remain better than peers at present, and the RAMI in particular is excellent at 83, putting us in the top 20% of trusts, or 17th out of 123. I've included the rolling RAMI chart for deaths from sepsis because this was raised at a previous board meeting, and currently we're doing really well and much lower than peers. If you look at the main causes of death in hospital, it's some of the usual suspects at the top of the list: pneumonia, cancer, sepsis, stroke, sometimes heart failure, sometimes myocardial infarction are up there, just depending on the particular month. But I would point out that COVID has not gone away as a cause of death. It's still there in April with 10. And as was alluded to earlier by Joe, there has been a slight increase in COVID in the south of England over the last week or so. Levels in the community have doubled in the last week due to the arrival of the new BA4 and BA5 variants of Omicron. And interestingly, in our CMDU, which is where we're giving the infusions to vulnerable patients who've developed COVID, there's been quite an uptick in numbers coming through that unit over the last week. So that fits with what the data is showing us. I think that's probably all I need to say. I'm happy to take questions on any of that.
Thanks, David. And I know I say this quite often, but we've got used to saying how fantastically well our mortality figures are, and we've kind of normalized them a little bit, but it really is fantastic news, isn't it?
Yeah, well, certainly 5 or 6 years ago we were an outlier the wrong way, so there has been a definite improvement.
Yeah, brilliant. Thanks, David. Nikki.
So what I'm about to say is absolutely in the context of recognising what Steve's just said, which is the headline is great. David was really kind and shared with me some of the underlying data that the wider team sees. And I just wondered whether there's an opportunity for this IPR. Sorry, I'm getting terrible feedback, so if anyone's got their thing on, if they could turn it off. I just wonder whether there's an opportunity to mix up this slide a little bit, which is headline fantastic, here's some of the areas where there are some unexpected trends or things, and this is why we think they're like it. Or so I was looking through it, and there's our elective versus non-elective, David, is perhaps not what we might expect. What have you done about that? Can I have the assurance that you've looked into it and you're happy because of X? Or similarly with acute cerebrovascular disease, why is that the way it is? Do we think that's patient mix, or the difference between the hospitals? Is that because of the cases that we see at Conquest? Just so we then get that next level down of assurance that is, actually, we're totally on top of this. Not only is the headline fantastic, where beneath it there's something that looks different. This is what we're doing about it.
So all three of those have been on the radar for some time and have been looked into quite closely. So we did a deep dive into the elective versus non-elective, and the problem is that, so for example, if you are sadly dying from cancer and you have recurrent ascites, for example, then you might come in routinely to have your ascites drained, and then if you die within the next 30 days, that counts against the shimmy. And so when we actually looked into the elective mortality, actually all of the deaths were expected deaths. And so once or twice, when it's flagged, I've looked at that. The issue around the different mortality between the two sites is a tricky one, and we've looked into that several times. There does seem to be a difference in the way the two sides get coded, and I've been trying to get to the bottom of that. And obviously the Conquest is slightly the hotter of the two sites in terms of getting all of the trauma and getting all of the acute surgical disease, and so that does lead to a slight differential in terms of mortality. But that notwithstanding, there does seem to be an issue around coding, which has been difficult to get to the bottom of, and I have BI working on that at the moment. Then there was a third one that you said, or have I covered all three? I think I may have covered all three. Yeah, but no, we do look at that very closely. So all of those things have been discussed in great depth. And if there was any, obviously, if anything turned up in any of those that I was really concerned about, so for example, if I really thought we had an issue with elective mortality, then that would come to the board. I can assure you of that.
Yeah, no, I think we've had the conversation before, David. It was more just, can we in this slide perhaps bring out some of that work that you're doing to almost formalize that assurance that you're giving us?
Yeah.
Thanks, Nikki. Jackie, did you have your hand up? And
so David answered. It was about the difference between Conquest and EDH, but David's answered it. Thank you.
all right, thanks. Okay, thanks very much, David. Thank you, Vicky. Shall we move on to workforce and our people, Steve? If you're able to talk.
I think I'll be fine. Thank you very much. Please excuse me if I do take a slight break along the way, but I don't think I'll need to. It's been alluded to before, but I'm pleased to be presenting a report this month which feels slightly different and more positive to those we've seen in recent months. I think this is predominantly due to the reduction in sickness numbers, but I'm also pleased to say that this trend has continued since the period covered by the report, and I'll come on to that in a bit. That's not to say things are easy, though. They're definitely not. But in terms of sickness, we've got 200 more colleagues available to work than we did at the height of the most recent COVID outbreak. And there's a small number of reduction in other reasons for sickness as well. To give you a flavour, we've got 52 people off with COVID today. That number's encouraging on its own from the 220 odd that we had. But the length of time taken off for COVID versus non-COVID is different. So 9 to 10 days for COVID, typical non-COVID sickness case is less than that. So again, that really helps us. And I think coming back to Nikki's question earlier around pressures, one of the things that really helps us with pressures is not just the number of beds that we have opened or closed, but also the fact we've got 200 more staff available to us who were off with COVID before makes a real difference to how it feels. But like I say, that doesn't mean it feels easy. David alluded to the blip over the last few days. Sadly, we've seen a blip in staff COVID. Hello. And That's gone from a low of 32 last week up to 54 today. So 52 today. So pretty much a 50% increase in the number of staff COVID, and it just shows the importance of still being careful and of the lateral flow testing programs for staff. In terms of our nursing, HCA, doctors and other ward-based colleagues, you know, they are feeling the stretch. Fill rates on shifts are better than they have been, but we're still stretched due to the requirement of the additional beds, and we know that's going to continue for some time and maintain our reliance on temporary colleagues. But just to remind you, we've got more nurses and HCAs than we've had before. Our recruitment continues to be strong, so we're in the best possible situation to support the current pressures and to see the benefits in terms of staffing as we reduce our COVID capacity and flow improves. We continue to review our staffing numbers and the profile of our staff, and this includes ensuring that we can offer excellent support and development to our supernumerary staff, whilst also ensuring that they're available to support the pressures within the system. A nice example of this is how we're working with our international nurses to provide them with a really good development experience as they work towards their OSCE, whilst at the same time giving them real practical experience on the wards, which really helps the wards as well as helping them with their development. I think Jackie talked about the new normal, and as we and I agree that we are coming to a new normal, and as we move towards it, we really need to concentrate now on how we help our colleagues to recover. We know people are tired, we know they feel less positive, and as a result of their experiences in the last 2 years, and we're seeing an ongoing increase in turnover, which is up to 12% annualized for this month, with the dominant reasons, interestingly, being around work-life balance, health and retirement, which is a shift from what we've seen before, and I know I've mentioned that at previous boards. We know that this turnover is hitting some services harder than others, with community being an area of particular concern, and we're working hard to support those. We can also be pretty confident that the scars of COVID, if you'll pardon the expression, are going to impact on turnover and staff morale for some time. We've previously talked about the staff survey at the board, and we should be really proud of our results and how they stand up to other organisations. But we also need to recognise that we've seen a drop in our scores, so our ESHT colleagues don't feel as positive as they did. You'll have heard me say many times before that it's important to understand how we compare, but I don't really care about that. What I care about is us being the organisation we aspire to be in terms of engagement. So now's the time for us to really concentrate on recovery. I think through implementing, firstly, our people strategy, we're progressing well with this. We've got 83 work streams, only 4 of them are showing as being behind at the moment. It's also the time for us to concentrate, make sure we're really concentrating on getting the basics right, as we know these make a real difference. Rostering at 6 and 8 weeks is disappointing, and we need to improve on that. Our job planning needs to recover. And we know that when staff get appraisals, they rate them really highly, but we're not doing enough of them. So there's a whole bunch of things there that we really need to focus on, remembering that, you know, we can do lots of nice shiny stuff, but if we don't get the basics right, then those are the things that make the real difference. So a very hard focus on those. We also need to focus on concentrate on retention, staff development, and the other things that we know work towards motivating colleagues, as we discussed in the last meeting. You'll get the sense from what I'm saying here that for the People Directorate, this feels like a real line in the sand. It's time to look forward rather than think about the challenges that we've had in over the last couple of years. There's a lot for us already to be really proud of. We're identified in the National Res Report as top in the country for Res Indicator 3, which is about discrimination in the disciplinary process. We're number 1 in the country for our ESR data accuracy. 10,000 fields were tested in April, 10,000 were correct. We're at the top of the tree nationally for Kickstart. We're providing access to people to work through the Kickstart scheme, and the numbers are increasing all the time for that. And we're an exemplar on health and well-being. But actually, that's not enough. Yeah, we need to keep this focus going, as we've said. I think it does feel like a time to recognise, and Joe's done this already, so thank you, actually the work that my team have actually done over the last 24 months. We often talk about the pressures faced by others, but this is actually a really tough time for some of the support teams, including the HR and People Directorate teams. We've continually supported people and teams in crisis, and this takes its toll. We know we're a top organisation when it comes to supporting health and wellbeing, but we haven't just focused on that. We've also focused on driving things forward. We're leading the way on new roles. We know we've got a really good strategy. We've kept things moving forward despite all the pressures we've been under, and that's taken a real effort from my team. So I just want to personally thank them at this point. I'm hoping this covers most of the information for the month, and I'll stop now and take questions.
Thanks, Steve. Inspiring stuff. Jackie.
And this is all in the context of recognising just how good we are in trying to look after the staff. But I've got 4 questions. When are the newly qualified various professions due, and would we expect to have a bounce in our recruitment as they all graduate? I'm thinking of the AHPs and newly qualified nurses. If people are feeling tired and exhausted, why do we still insist on having such long shifts? That's my second question. Is there anything more we can do to help people with the cost of living, perhaps more so our community staff in terms of travel? And my last question was, the time to hire is averaging out at 60 days, which is not too bad, but is there anything we could do to get people onboarded quicker?
So the 4 easy questions for you there, Steve.
Yeah, I guess in the spirit of the board so far, I'll hand them over to Tara. No, I won't. In terms of newly qualified, we from a nursing perspective, we've got our international nurses coming through every 2 months. We get 20 about. Let me try that again, between 20 and 30 every 2 months. So we've got a constant flow of people coming through there. We've got a vibrant new to healthcare programme, which actually gives us HCAs now on a weekly or monthly basis. We are running frequent boot camps to bring people in. So I think in terms of our newly qualified nurses and docs, actually, I don't think they give any. I don't think they give any respite, because there's a constant churn around that, and when new people come in, there's lots that they need to learn. But what we have got is a bunch of other programs that we've put in place, which a lot of them linked around new roles, which mean that we've got a constant churn of new people coming into the organisation, which is hopefully taking the pressure off, both by supplementing existing numbers, but also through the boot camps that we're running, places like ED, community and the likes, actually bolstering the skill base in some areas which are really challenged.
Just on that, Steve, I think the attraction of newly qualified is an indicator of how people view us as a trust. So it tend to be the more you can get from that cohort, the more it seems like we're doing a good job. So that was why I asked. Yeah,
and I mean, on that point, and I mean, Joe and I were actually talking about this last week. The quality of consultants that we are seeing coming through and applying for roles at the trust, and when they're asked why, the response, which is pretty much, well, because it's ESHT. You know, we've heard about ESHT, we know about ESHT, we know it's a good place. Is I think a really good indicator. The other things we're seeing with Kickstart, New to Care, and some of the boot camps is we're providing opportunities that don't necessarily exist elsewhere, and people are getting really excited about it. We are, in fact, actually at the moment, we've been so successful in some of the new to care areas that we're running a pilot at the moment through our recruitment team to actually support the recruitment of healthcare assistants into the local authority, and indeed even to support it with the independent care sector, to actually help with some of the challenges in those areas. So I think, you know, we are able to use our reputation in order to do that, Jackie. In terms of tired and exhausted and the long shifts, it's a really interesting one, because we know from talking to colleagues that the preference is the long shifts and the breaks. And that is something that we do stay very close to. We do try to offer alternatives, different ways of working for people. You know, flexible working is a way in which actually we can attract other people. But certainly the longer shifts are something which from the feedback we're getting is supported at the moment rather than not supported. Cost of living is obviously a challenge for everyone, and you've rightly, I think, pulled out the community staff and mileage rates and the likes, and there has been some national discussion around this which hasn't concluded on any on any changes, but we are right in the middle and I think very close to some decisions at a system level, at an ICB or ICS level, around what we might be able to do to support people around around certainly the cost of travel, those people who are working in our community roles. We're very clear that we would want to move as a system and to support each other as a system in this, so that we don't create an internal market which would be both unhelpful and wouldn't be motivational. The fourth question you asked was around time to hire. Our average time to hire has moved down to 71 days, though we're hitting closer to 60 days actually in the last couple of months. What we need to remember is that actually includes notice period, and that includes time for turnaround for interviews and things like that. If you look at the actual time to offer, excuse me, bear with me. I was doing so well. If you look at the time to offer, that is actually significantly shorter than that. But what we are doing in order to bring people in more quickly is we are actually looking at where we can bring people into roles on a supervised basis, which we can do in some areas, which actually means that we don't necessarily need to complete. We need to complete obviously basic checks, but we don't need to complete the full range of things that we would actually for someone to come in on an unsupervised basis. But we are very cautious of doing that, and we know that our average time to hire is good compared with our with colleagues elsewhere. I hope that answers those questions. Yeah, okay, thank you.
Thanks, Jackie. Miranda.
Thank you. I'd like to congratulate you and the team, and indeed everyone in the organisation, on the fantastic performance with regard to the leadership and management of people. It really is in a different place. And what I wanted to ask you, I still think I want to say this, but I've slightly changed how I feel about it listening to your presentation. There's a bit of a disconnect between what appears on the cover sheet for the whole IPR, the kind of dashboard at the front, and how you've presented this, which is much more upbeat. So there are many matters shown as being of concern on the front sheet. So I'm hoping that perhaps that's a matter of timing, and that as we go forward, there'll be fewer matters of concern under the people element of the dashboard, because your presentation is more upbeat than that.
I think that, I mean, the 2 points. Firstly, the report relates to April, and we are in the middle of June now, and we've seen ongoing reductions in sickness numbers, whilst our bed pressures are pretty tough at the moment. We've seen you know, we have seen some beds freeing up. We've seen we've seen some improved flow, and those things all make a difference. I suppose there's two parts to this for me, Miranda. There's firstly, how does it feel right now for people? And the message that we were getting through the IPRs is it doesn't feel quite as tight as it did, and therefore it feels more positive, and it feels like there's the opportunity to take a bit of a breath. And on that side of it, you know, that would be my biggest ask right now, is that actually people feel that they can, the things feel slightly less pressured. The other side of it is to do with turnover, really. I think at the core of it, and the impact of that, and us having to run faster and faster and faster to stay still, as it were. But I really hope that as we come out of this, I said in my update, you know, I think we'll see the scars for some time, but actually what I feel positive about is that we've got something to work with now. We've got something to work on, rather than just sort of the crisis management approach that we've that we've very much had to sort of instigate over the COVID period. And I think that's my positivity comes from the fact that we can look forward and we can really focus at going above and beyond, rather than just doing the basic stuff over and over again to stay safe, make sure we do the best for our staff and make sure we do the best for our patients.
Thank you. I'd just like to add one more thing about health and well-being on an anecdotal basis. I've been in my capacity as the well-being champion of the board to a Southeast session on this, and all the initiatives we are taking and our approach to this is really, I think, first rate. And I had to almost avoid lobbing in too many ideas because we do so many brilliant things and not dominate the conversation. So well done on that as well.
Thank you.
Thanks, Randa. That's a perfect point to draw that section to a close. I'm conscious both of Steve's voice, but also the timing, and obviously Tara has got a lot to cover. So over to you, Tara.
Thank you, Steve. Hopefully I can try and solve world peace, but I will just cover my piece as per the IPR report. Firstly, I'd like to just take the report as read, as others have, and draw out some key highlights that I believe are directly linked to the Trust strategic priorities, but also to the unprecedented challenges that we're facing this year, both with a financial and activity point of view, while maintaining high quality services. But one thing I would like to draw out is myself and Vicky had the pleasure of showing Stephen Lightfoot, the incoming chair of the ICB, around the Conquest site a few weeks ago. And as I've said to the teams, I was very humbled to be able to show off our services and our staff on their behalf. And I think it was just testament to everyone, and a massive thank you to everyone that supported that. No orchestration needed. Everyone was brilliant, and he was really impressed with what he saw. But just to say thank you as well, not just to our clinical teams, but all of our support functions that work around us, especially the estates and facilities team, because they do an amazing job every day. And a lot of the flow that we managed to achieve recently is with their support and quick turnaround. And also to our admin teams that are silently working away behind the scenes, that don't always get the big shout out that they should get as well. So I suppose the first significant piece of work that we've got to do is to reduce the number of patients that do not meet the criteria to reside to 50. We're currently averaging over 200 per day at the moment. To achieve this, we're working with our system partners to identify and agree a system-wide model in line with the national withdrawal of the hospital discharge fund. It's not going to be without its challenges to discharge patients in a timely fashion due to the shortfall in onward care available and the pressures on our adult social care colleagues. However, the Trust teams are working through how we can promote and increase at pace the use of the virtual ward models that we've identified and what we must do internally to expedite discharges. We're currently recruiting to our Home First team to significantly increase our capacity available to support patients being discharged back to their usual residence. So that might be their home or to their care home where they've come from. And this will be a short-term sort of support package tailored to the individual needs. And this goes in part to the point about being able to close some of our escalation beds. So the increase that we're putting in the Home First capacity matches the number of beds that we have open at the moment as escalation. This piece of work is moving at significant pace. The aim to agree the model for the system-wide piece and the bed numbers available to us both virtually and physically is due this afternoon. We have a silver call later on today, so we'll be working through that for presentation to the Chief Executive Group on the 20th of this month. We have seen, as we've touched on earlier, an improvement of our use of digital systems to support and plan for the influx of patients through our ED, but also for our discharges. So we're looking at increasing our weekend discharges. And although we acknowledge these are usually the simple discharges, and I use that word lightly, we will we are delivering on that, but we must acknowledge that we don't always see an increase in the support packages available and the ability to settle patients into care home settings over the weekend. So we are focusing on those simple and home first care packages that we can provide. Moving on to our elective recovery. The delivery of the 104% against the 1920 baseline activity in month 1 and month 2 have been compromised by the surge of COVID cases, which resulted in a subsequent closure in some of our elective beds to provide medical capacity. This was at a detriment to our ability to provide elective bed capacity. However, as a trust, we looked at our elective case mix and adjusted that where possible to increase the number of day case activity that we could bring through to mitigate the impact on our elective case mix. So we obviously continue to do all urgent and cancer cases without interruption. The trust did fall short of its own trajectory in these months, but we are looking to how we can mitigate this by year end. So we're not saying that we're not going to deliver. We are going to mitigate and increase throughput as we can, and we are seeing now the stepped increase as we are bringing back online or have brought back on all our elective capacity. We also have seen a delay in the delivery of the Theatre 5 and 8 refurbishment programme. This is due to, and I hate to say that word as well because I can't solve that, the result of Brexit, which is something that was been masked for a little while, but we are seeing the struggle to bring equipment and supplies into the building trade, and Chris may pick that up at another time. But we do plan to compensate for that as soon as those theatres are back online. In a positive note, the diagnostic ask was that we delivered 120% of the 1920 baseline activity. This has been delivered in months 1 and 2, and we expect this to improve further as we open our community diagnostic centre in August, with full ramp up expected by October. And for those of you that are keen on social media, we did actually put up an artist's impression of our CDC and explain what was happening. And we've had some really positive comments back from our patients and public around that. So again, that's another exciting thing for us here at ESHT. As a trust, I'm proud to say we have 0 patients waiting over 78 weeks on our RTT reportable pathways, and community waits are undergoing validation and actions to reduce the current waiting times. Adult community, we have 0 patients waiting over 104 weeks, with 20 patients waiting over 52 weeks, and the divisional teams are working to date these patients now. They are in areas where we know that there have been staffing shortfalls, so we are working to look to see how we can do that over the coming weeks. In community paediatrics, we do have 115 patients waiting over 104 weeks. This, however, has been a long-standing issue as a result of consistently high referral rates. And to put that into context, as an organisation, we're only commissioned for 800 patients per annum, but we've seen and have been receiving referrals in excess of 250 per month. The teams do all they can to ensure that they see urgent referrals and that there is a longer waiting action plan with regards to reduced waiting times. In cancer services, we've seen a rise in patients waiting over 62 days, and this does correlate with the spike in referrals received in March, which was the second highest volume of referrals that we've ever received. As a trust, we continue to deliver against the 62-day ICS backlog trajectory, and I will flag that we will see a fall in performance in certain specialties as we have to address some workforce issues that have impacted on capacity available. But we're expecting to see a step change recovery with oncoming recruitment through August. In urgent care, as we've discussed earlier, we remain in the top 50% of the 112 reporting trusts for urgent care. But of course, I and the team will also strive to ensure that we remain in the upper quartile where possible. We are going out and working with other organisations to see what they are doing to make sure that we can learn from others and bring that learning back to the organisation. I'm off to Norfolk in a couple of weeks, and we'll be spending some time to understand their virtual hubs, their discharge hubs, and what they're doing at the front door, so that we can learn and obviously bring that back far and wide. In month 1, we placed 51st in the overall urgent care performance, which is calculated over a 4-week rolling average. We know that the patient flow through the trust is impacted by demand and delays in discharging, but we have identified that if we drop below 35% of our activity going through UTC, it has a detrimental impact on our performance. And I can say that we are seeing a significant improvement on that. And over the weekend alone, we saw 51% of our activity going through our UTCs. So Jackie's comment is also well received as we see that stepped increase. Our ambulance handover performance is closely monitored and delays are escalated through the operational teams, and we also meet regularly with CCAM to ensure that any trends are identified and addressed together. In the main, we are recognised as a well-performing trust that prevent delays in ambulance turnaround, and I had that feedback directly from CCAM myself yesterday. So that is the sort of overview, and I will stop there and open to questions.
Thank you, Tara. Very comprehensive. Jackie, would you like to start?
Thank you. It still feels like a quart into a pint pot, doesn't it? And that we're seeing, length of stay, seeing waiting list size, and I'm conscious that particularly in urgent care, we have got high vacancy. So I'm a bit worried that how do we get out of our escalation beds, or we get funded to do them differently or something, because it does feel like winter hasn't gone away in terms of workload pressure. Can we see, I suppose it is the success of the UTC and perhaps more success with social care to allow people to get out, but are you more positive? Because winter's coming very quick, I think, in my pessimistic world. I'm just not sure we're going to get there in terms of balancing the quart with the pint pot.
Yes, Jackie, and the NHS official end to winter was the 19th of April, so we've only really just stepped out of it, and I think I haven't had the start date yet, but we are already planning for winter. So we have been able to close some of our escalation beds over the last few months. Unfortunately, we do have to reopen them now and again, but we are flexing our activity. You're right, we have got issues around capacity for the onward care, but we do work very closely with our adult social care partners to see what we can do and what we can do differently. And the one thing I will say is we've really started to address the culture and the understanding of the full pathway. And we can concentrate on little chunks of it. We can look at the front door and UTC, but we also need to understand the impact and the interdependencies that everything's got. So we look at the front door, we know that the UTC, if we drop below 35%, that will have a detrimental impact on flow. We understand that now. So we really look at the UTC and see what we can do to support and influence them. We've put the redirection tools in. So as we've already talked about eConsult, but we also have eRedirect. So we now have the ability to redirect patients to pharmacies, to optometry, and we are actually starting this week to redirect to dentists. So we're looking at what we can do there to redirect patients to the right place and decompress the number of patients that come in. When our patients are in our ED setting, where we can, we are using our adult social care support that's on site and redirecting them to that environment where we can, so that we can try and prevent admissions. We do, although recruitment is challenging, I can say we are seeing an improvement, as Steve has already said, about the patients, about staff that want to come and work with us within the organisation. And we have done some things really differently, and we've brought in, and I just think about this as we've done doctors' assistants. So these are doctors from overseas, they've got their PIN number, but they haven't really got NHS experience. So we're bringing them in, they're working alongside our ED and our discharge staff. and then they're having such a good experience, they're actually being recruited not only into our organisation, but they're getting jobs elsewhere because we are training and bringing those people in. With regards to elective, we really have put the, I call it a moat, my green moat around those beds, so that we can make sure that we can continue delivering that activity. We're working with other providers to ensure that we're validating all of the time, and that our waiting list size, although it will grow, it will ebb and flow with referrals, that we are only dealing with a really clean waiting list. And I think that's really, really important to note. And then with regards to discharge, as I've said, we're looking at what we can do as a whole system, but what is it we can do as an integrated trust? So we are thinking really differently about a community ESHT, so that patients can be seen in that community environment, picked up quite quickly, supported to stay at home, not having to come around the full loop. So am I worried about winter? Yes, who wouldn't be? But I think it's everyone's worried about the unknown. Have we got an amazing team that still want to look and think differently? Yes, we do. And I think that's the thing that we've got to hold on to, is with our home first team, and the teams that come into the trust every day and say, okay, this patient needs X package of care and this to be discharged. How can we do that differently? How can we make sure that we're using our volunteers and our take home and settles teams? Mother Teresa is one that I always use. It's a voluntary sector, and they'll take meals into a patient but also do a check. So we really understand the full gamut that we've got available to us. So it's not easy. If I really did have the answer to that, I think I could solve world peace and a few other things. But what I have got is an amazing team, not just with my exec colleagues, but with everybody through the organisation to help resolve some of this.
Thanks, Tara. Amanda?
Tara, I have nothing but admiration for you, your energy and your absolute understanding and description of the complexities, because there is absolutely no doubt that this is hugely, hugely complex. But so I'm a fairly simple person, and my mathematics tells me that actually if we were to get the people who are fit for discharge out of our hospitals, we wouldn't have a problem. And actually, you know, it's not about that. It's about making sure our population is getting care where they should be getting care, and for their sake, because we know of the repercussions of people being in hospital and not in the right place is not good for them at all, is it? So I suppose my question is a simple question, that all of those things that we are doing, we keep coming back to this same issue, don't we? The people coming in our door, and you're doing all of the great things there, but the back door is the issue. So in our partnership conversations that you have, and I know you lead with great ferocity, is there one new thing that we're going to do that we can apply now that will prepare us well for winter? Because I, like Jackie and other colleagues, we're not out of the escalation pairs. We're not out of that feeling of intensity, are we? So how do we decompress our organisation in order to prepare for another escalation, which is only going to be weeks away? And there's another question I have. That was one. And the second one, out of what do we know the patients that we redirect from our front door? Do we know of the patients that come back to us, that bounce back to us? Yeah,
so I'll try and cover a few things off, Amanda, and like I say, I haven't got all of the answers. No, I think one thing that we could all do as a system, and we have had this conversation and we continue to have it, is it's not just what we need to do for patients when they're in the system, it's what we need to do for the public before they become patients, and the carers of those people that are patients at the time. And we talk about not meeting the criteria to reside, but I think it's about making that a language or an understanding for everybody outside of health. Because when we're having some conversations with patients and patient relatives, it's quite difficult for the staff at the time. And that can delay a length of stay. So we are working on how we can do that, and we're using partners like Health Watch, etc., and our GP forums. The other things that we're doing to try and be forward thinking and keep patients out is working with CCAM. As I've said earlier, we have Livy. Many of us know that we've got the Livy and the GP appointments. This week we are working with CCAM, so CCAM can use the Livy slots that we aren't using as the acute provider. So instead of CCAM having to convey into us as an acute and then us redirect to UTC and then from UTC to a GP appointment, CCAM are going direct into that capacity. So we do know the patients that we redirect elsewhere, and we can monitor those for bounce backs. But also CCAM are doing the same sort of thing. So we do know, and as we develop more and more community capacity, then obviously we'll be able to monitor that further.
Jo, did you want to come in on that?
I'm going to try and give Tara a breather. I'm just going to come back and directly answer. Well, actually, Tara has done it, but I just wanted to come back on Amanda's question about is there what's the one thing? There isn't one thing. This is a number of internal continuous improvement actions. It's a number of initiatives that I'm not going to repeat because Tara's just been through those and we've talked over time. Steve, Phoenix and I are meeting with the local authority in a couple of weeks' time, but there is no magic bullet here. This is all of the above and more, and some are mitigations. And what it's worth just reminding people, and a lot of us have been around the table for a long time, others less so. 5 years ago, we took significant days off of length of stay. We went from one of the bottom decile provider to a top decile provider in terms of urgent care performance. We've done this before and we can do it again, but this is different. And Tara and I talk all the time, as you might expect. This is not the same as 5 years ago. But in short, Amanda, no, there isn't one thing. It's all of the above and more, which is why we need to have the Urgent Care Summit, because we've done all the things that we've got in our toolboxes, so we need to think of something else. And should we be worried about winter? Yes. And what we'll do is we'll firm up our plans. We'll make sure we've got, well, we've already got it. We've got our bed numbers. We know how many beds we need. We know what the impact is of various initiatives. But it's going to be a hard winter, and I don't think we should hide from that. I think we acknowledge it, and then what we talk about is the mitigations and making it as good as we can do. But there are lots of things in place, so I don't want that to be a negative. Teams are working hard, but I don't think we should leave thinking we're going to have a brilliant winter, because I think it's going to be difficult.
Thanks, Jo. Unless anybody has anything burning further to ask, I'm mindful of the time and I'm keen that we get onto finance. So so thanks very much for all of that, Tara. And Damien, over to you.
So I'm hoping to talk about a good summer before we start talking about a hard winter, because we actually have some work to do. Can I just remind us of where we were in April? We had quite a tough February, March, where actually we had really high levels of sickness. And as we came into April, I agree with Stephen Meyer, we did improve, but we actually had the ongoing effect from coming through from March, which did leave relatively high levels of sickness, and we had the ramp up of target to try to get to the 104%, which actually just pushed on the escalation beds. So we ended up having, relatively high levels of temporary staff through April. In fact, we had 3.1 million being spent on temporary staff against an average last year of about 2.8. So that was one of our core drivers. We also had a deficit, a planned deficit in month of 0.5 million. We actually ended up with a deficit of 1.1 million. And that was primarily caused by not quite hitting the elective recovery plan. So we were actually short by 900,000. And I know that I try to avoid giving too many numbers in the finance update, but those are quite big numbers for us to understand. What we're basically saying is April was a hard month, and as we are going into April, into May, Tara has said yes, we haven't quite delivered in May as well, which actually is also true. I think the important thing for us to remember is the point that she's made about theatres 5 and 8 hopefully coming online by the end of June, although Chris might shoot daggers at me over the screen, and then making sure our day case capacity also improves with a day theatre in July. So those steps should help us to drive activity back to the target level through the rest of the year. While we're doing that, you know, we need to deliver the flow points that Tara's made, which are specifically around making sure our investment in Home First works, and exit flow also works, so that we're able to deliver on the escalation ward improvement, which we've signed up to as a plan, but we need to see those steps over the next 2-3 months. So those are how we need to be able to deliver the year. We also need to finalise our savings plan, which frankly linked to those two themes anyway. But we are at the moment short. Well, we were going to be short by 7.7 million. It looks like it's going to be 9.5 million now that we've had an increased ask on us to try to deliver break even. But again, they're the same core principles. Can we deliver the plan to reduce the escalation beds, and can we deliver the elective plan, and can we do it without reliance with the current levels of reliance on agency? So those are the three drivers that we can already see from month one. I mean, in terms of pay and non-pay, we did face slight pressures, and I'm expecting those pressures to continue through the rest of the year. It's not just a question of focusing on those 3 points, but it does help to say, you know, what exactly is the continuing theme between the points that Steve and Tara have made and how we deliver this year. I think one final point I'd make is, because the challenges are so hard, we need to be really focused on understanding the cost pressures that we're facing over the year, and, you know, just understanding that if we do sign up to any increases in some of the business cases and cost pressures that we need to consider over the next couple of months, it will be very hard to deliver this plan if we accept any of those cases, or a significant amount in those cases. So I'd repeat the point. You know, we know what the target is. Those three themes are the themes that I want to pick up on. And in terms of delivering the savings plan, we have more work to do. In mitigation, it's worth saying that we haven't quite finished the budget. The final submission of the budget is actually on the 20th of June, and we have just been asked to increase the commitments that we've made. So it's relatively new for the divisions as well. That's why when I've talked about having 7.5 million initially unidentified, possibly closer to 9.5 now that we're trying to take on an increased level of ambition, we also need to develop more clearly our savings plan to be able to deliver those plans. So can I hand over for questions at that stage?
I wondered whether you wanted to add anything, Joe, before I move to questions.
No, not particularly. I think we're trying to support the system and get it right for our organisation, but also the system as well. So nothing more to add at this moment in time.
Thank you, Chris.
Thanks, Steve. I just thought I'd come back to what Damien and Tara said around the theatre scheme. So we're doing two theatre significant refurbishment schemes, actually. one at Conquest, one at Eastbourne, and one at Conquest is just due to be handed this week, actually handed over. That's a fantastic new theatre environment, 2 operating theatres in the team. I think we'll think that our environment is fantastic. The other one has a little bit of a delay, has been said, for the reasons, i.e. supply chains, COVID, etc. So we're working with the supplier, and that'll be delivered shortly. So it's just worth saying that those 2 sets of theatres, refurbishment, or 2 theatres on each side, are a really good scheme, and they will benefit our clinical colleagues. Thank you.
Thanks, Chris. Any other questions for Damien? If Jackie?
Sorry, just to, I suppose, given that what Damien has said, is there a series of structured workshops or meetings or whatever so that we do close out that saving plan quicker because it's already June?
So shall I wait for Joe to come in and then
I was just going to say there's 2 things that I'm just planning at the moment, or we are planning at the moment. One is a workforce summit. I'm into the word summit this month, you can tell. I'm in a workforce summit. I want to go through, and we've had a brief look as execs, I want to go through every increase in staff, not necessarily every line on every, but if Ward X have got an increase in staff, or corporate area Y have got an increase in staff, I just want to go back through and be really clear what the staffing increase is. Was it a, and we're talking about substantive usage for the purposes of this. Is it something we signed off previously? Is it a conscious decision? Is it still the right decision? It's not trying to take out staff necessarily. I just want to make sure we're really clear on those decisions, or whether we've got some hangovers sort of the last couple of years that we need to sort of readjust a little bit. So that'll be an all-day workshop. Second workshop I want to do, and Damien probably doesn't, I think we've alluded to it but haven't put the arrangements in place at the moment, is to do a SIP workshop and to go through with the divisions line by line. To test the robustness of each of those plans, but also to be a supportive what's not in there. I think, to be fair, the divisions have only just had their budget, so they're looking through, I think, to better understand what else they could do to contribute towards that. So that's my plan, is 2 sort of detailed executive and divisional workshops or summits.
Thanks, Joe. Okay, if there are no other questions, thanks very much, Damien. Sharp-eyed colleagues will see that we are significantly behind timing. I think we're likely to be able to make a good chunk of this up as we proceed, but I'm going to suggest that we take a break now. I make it 12 minutes past. Can I suggest we reconvene at 25 past? Is that okay with everybody? Excellent. See you in 10 or so minutes. Thanks. Right. Welcome back, everybody. Hope everybody had a chance to get a drink and a bit of refreshment. Let's move to agenda item 8, and as we said at the beginning of the meeting, although the paper itself is withdrawn, Vicky and I think David are just going to talk us through what's in the new guidance and how we respond to things. Are you starting us off, Vicky?
Thanks, Chair. I will, and Dr. Ocker, as always, will join me. So apologies, we had submitted a paper, but that was superseded by more guidance recently. And since the infection control guidance, there's also been updated guidance regarding visiting. So a number of us have looked at that and updating our policies and website accordingly. So you may well see that if you log on. It is important to say that all of the national guidance previously and currently does still refer to local risk assessment, given the variation of hospital estates in particular, space and ventilation and of infection levels. And as we've said today, we are closely watching the local prevalence, albeit hopefully that will remain very low. And it is important to say it is very low. At its peak in the second wave, our levels were 1,200 and above, and at the moment they're in the 70s and 80s. So they are significantly low, albeit a little bit higher than the England average. David and I will be very happy to take questions, but I think in simple terms, with regard to mask wearing, that's something that everyone is very keen to talk about and understand. We've got our headlines for staff, for patients and for visitors. And if you visit any of the hospital sites in any of our non-clinical areas, you will see far more staff not wearing masks. And I'm at Eastbourne today, and it was lovely coming in that we get to see far more of our staff's very happy, smiling faces, I have to say. Important to say that we have said to our staff that in certain situations, if they do want to continue to wear masks, then that is absolutely fine, and we will support that. It's fair to say in the last 2+ years, we've all been on the journey and we've lived and worked in a very command and control environment. So people are at different points in their journey coming out of that. So we're very mindful of that. For patients, we have tried to keep that fairly simple and straightforward. So significant reduction, but we do ask that until patients are triaged, that they wear a mask if they can, unless they're exempt. So that will be most of our front door areas in line with national guidance. And similarly for visitors, we would ask that they do continue to wear a mask if they're visiting vulnerable patients, or of course a patient with suspected or confirmed respiratory infections. With regard to visiting, we relaxed our restrictions quite some time ago in line with the national guidance, and having benchmarked recently with 7 other trusts, most are applying the national guidance, but it does vary from organisation to organisation. And I think the 2 things I would recommend that we maintain our system of booking visits in advance. That is helping us to manage visiting in a safe way. And also it's important to remember that in terms of visiting, we do have to consider that patients do need rest and time to recover. We also need to ensure that our staff have space and time to care for patients and to keep the environment clean. And also large numbers of our patients are frail and confused, and in terms of privacy and dignity and us being able to protect that for them, then we certainly wouldn't want to move to very crowded bays. So I think it's important to state that as well, that it's not simply about infection control measures. So we have also, in line with the national guidance, reviewed and revised our approach to testing and cleaning and isolation. And as an ICS, we have an agreed and standard approach on that. So Chair, I'll stop there in case there's anything specific that anybody wants to ask, and I'm sure Dr. Walker will want to say a few things as well.
Thanks, Vicky. David, do you want to come in at this point?
Just briefly on testing. So we're continuing to do PCR testing for all admissions. We have the rapid turnaround PCR tests, so result within an hour, and we're still in line with national guidance. We've switched over from PCR testing of inpatients subsequently over to lateral flow testing, and so patients are getting tested at days 3 and 5 with lateral flow testing. So that gives us a much more rapid answer. Obviously, lateral flow testing isn't quite as specific or sensitive as PCR testing, but it really isn't bad. And so we're using that, and it gives us a very rapid response. And the nurses have adopted that with some enthusiasm, as opposed to doing the previous PCR testing. If patients are, we think, exposed to COVID as an inpatient, then we're doing daily lateral flow testing until we confirm that they're negative.
Okay, thank you, David. Questions? Miranda first and then Amanda.
Thank you. I know of at least one neighbouring trust where in most places you don't have to pre-book a visit. So I wondered what our justification was for taking a different approach on that.
So I don't know what that is, obviously, Miranda. What I do know is the 7 trusts that I've spoken to are all taking a different approach. Some are pre-booked, some are not. Some will have different numbers of visitors per patient. Some will ask that it is the same people that visit, some trusts don't. So I think it's very varied, actually, although there is national guidance. And some of that is because of the estate of the particular trust. So trusts do vary. So what will work in one ward on one site may not work quite as well as another. I think we adopted the pre-booking system some time ago. We haven't had complaints from patients or visitors. It's certainly very popular with the staff. And I think they feel that it gives them the ability to really safely manage that, so that we don't have periods of time where the bays are very crowded. I think it's important to say as well that our clinical areas are very busy. We have equipment. They were built at a period in time, so we do need to be mindful of the space. And also thinking back to the conversation about falls, you know, we want to make sure that the environment clinically is not overly crowded. So I personally think it's right that we keep the booking system. And as I say, we haven't had complaints from patients or visitors. And we'll keep that under review, of course. If something changes, then of course we can look at that.
Thank you, Amanda.
Sorry, Vicky, it was just to clarify. So obviously mask wearing in clinical areas, you said, yes?
Yes.
Yeah.
Well,
and
yes.
No, go on.
I was going to say, so I was trying not to take up the whole meeting with going through the details of the guidance, which is on the website. But there generally you will see far fewer staff wearing masks. However, we've tried to keep the guidance simple but clear, and said to staff that really this is about the principles of infection control. This is about transmission-based precautions and based on symptoms and risk and all those things. So I think it will take a little time for all of our staff to understand that and get to grips with that. And I suspect over the next few days and weeks, staff will become more familiar with the new approach and settle into the guidance.
And the second part of my question was front-facing services. So A&E is clear with masks. Does that apply to outpatients as well? And those.
So outpatients will be different. I mean, outpatients won't be required. We will ask that if people are unwell, then and asymptomatic respiratory illness, then clearly they don't come in. But no. And similarly for inpatients, generally we won't ask them to wear a mask all of the time. And if they have respiratory symptoms and are being moved to radiology or to another ward, then we would ask if they can wear a mask, that they do. So there's some complexities, but I'm hoping that we'll familiarise ourselves and all of the staff as the day weeks go.
Thank you.
Sure.
Thanks, Amanda. No other questions for David or Vicky? Okay, thank you. Thank you both. Shall we move on to agenda item 9, David? Regular report.
Yes, thank you, Chair. This is regular report, so you're used to seeing the graphs. The medical examiner process continues to work well and all deaths are being reviewed. Our mortality review group continues to review all deaths about which there's any concern, be it a complaint or any issue. I would say, just as a point of clarification in the figures here, the reports into COVID, and particularly the big surge of COVID that we had Christmas 2021, were not complete when we had our last mortality review group, and so all of those patients who with COVID will be reviewed at the August meeting, and so these figures are subject to change from that once we've had a chance to review them all. But apart from that, I've no particular comments on the data and happy to take questions.
Thank you, David. I've got Jackie first, then Nikki.
David, what happens if we scored someone at 3 or less that is possibly avoidable? Does that impact on our duty of candour? Do we do anything with that externally?
No, if only when they're probably avoidable. We would feedback if we review a death at the mortality review group and we feel that what we have done prior to that was not complete. For example, duty of candour should have taken place. Then we feedback that back to the individuals concerned so that they can pick that up.
Okay, thank you.
Nikki.
Yeah, mine was in a similar vein, I guess, and this is probably grumpy Nikki because I'm feeling rubbish. But I was reading this thinking we get the same paper every time, which is called Learning from Deaths, but I don't ever know what our learning is, and I don't ever know how the loop is closed to make sure what we've learned is implemented. So I guess it's a request for the future to bear that in mind. So rather than getting the same graphs that tell me I shouldn't be overly worried because the numbers are very little, the bits where there's even a little something, how do I definitely not worry that we're doing everything right in respect of those?
So obviously this was a system that was introduced by Jeremy Hunt, and the requirements for that and what is supposed to come to the board are very narrow and specific, and we stick to those narrow and specific guidelines with what comes here. And although it's entitled Learning from Deaths, and look, you know, we're not expected to discuss every death and what the learning was from it, and obviously you get that in other aspects of what we give you, for example in the SI reports and AMBER reports from the clinical governance team. So in a way what you get from those reports is the same as the learning from the deaths in terms of any issues that might have taken place. This was introduced to make sure that there's a system in place to review deaths, and that we looked very closely at all deaths and whether or not there were avoidability and things that we could take on board. But actually, the report is basically as we're required to do it. But I'm happy to discuss with you offline about any other issues, of course.
So there's my comfort that either quality and safety would see anything that came out of these.
Absolutely.
Absolutely. Okay, perfect. Yeah. Thank you.
Yeah. Thanks, Joe.
I was just going to probably say what Nikki just said. I think as long as we've got Q&S providing that assurance, if there's anything you're particularly concerned about or would like reassurance from, perhaps we could ask Q&S just to go through that process.
No, there's no need. Thank you, Joe.
Thanks, everybody. So I think that takes us to agenda item 10. We've touched a lot on the business plan sort of in the round as we've gone through items this morning. Joe, do you want to say a word or two about this before I ask Richard to speak on it?
Yeah, just very briefly, really. So as I sort of hinted at earlier, whilst obviously we've had business planning in process for years, it changes on an annual basis, just in terms of timelines of when information is available, when the planning guidance comes out. And obviously now we're working at a system level. So, and as already alluded to, the final plans are not due for submission until the 20th of this month. So this is still a working draft, and we already indicated that the divisions have just had their budgets and so are working through in a level of working through that. What we're also trying to make sure that we're clearly aligning are the priorities for the trust, and I know Richard's going to cover this, so apologies, I'm going to steal his thunder a little bit. We're making sure that we're aligning our trust strategy, the priorities for this year, and that flows very clearly through the divisions, and that we've got clear KPIs so that we can report back at board, and we'll be adapting the IPR to accommodate for that. In terms of the documents that you've got in front of you, as I say, they are still working drafts. But Rich is going to cover that in a little bit more detail in a second. In order to bring this to a conclusion, what we'll be doing is working with the divisions over the next few weeks just to firm up their plans. making sure we've agreed what those are in a reasonable level of detail, and then we'll provide a final version of this. It will be less detailed than this. I want it sort of as a document that's appropriate to share, and so a little bit shorter than it is at the moment. And then what we'd suggest is that comes to F&I in July, and then we can finalise that soon afterwards, and happy obviously to take comments offline as we go through that process. We'll make sure NEDs are engaged through the process, even if it's offline, just for timelines. Obviously it sort of impacts on all of the committees really. So that's all I wanted to say, but I know Richard will sort of take us through a little bit more.
Well, so just before we do then, so just on that latter point, Joe, I mean, I guess what we'll want is, I don't quite know how the right way to do this is, but I guess we want to be at a place where the board, the wider board, has an opportunity to understand and contribute to final decisions before it's at a point where there's, as it were, nothing really we can do other than sort of receive and note it. So I'm not necessarily looking for an answer now, but if we could just have that in mind, and whether that's F&I, whether it's a kind of online extraordinary discussion, whether, you know, I don't have a strong view about how we do it, but
so I think my recommendation would be that it comes to F&I, but obviously we can do a round for those that are not at F&I. I think the important thing is that the level of detail at division is really, I think, for execs to go through. So what I think the important thing to comment on is the overarching trust priorities, the projects that are associated with that. So it's the first paper. And how we will know, because you're going to ask me, how will we know that we've delivered the priorities that we've set? So it's the first paper really that I think is a focus, and that I'd expect the board to be signing off rather than the level of detail that sits behind it.
Yeah, I agree with that, and I mean, other NEDs will speak for themselves, but from my point of view, I guess the question will be, what's our confidence level in the deliverability of the plan, and what's the confidence level amongst our kind of clinical leaders? So and I'll leave that comment there. So I guess there's probably not much point in us debating the particular content of today's paper. More a question of just kind of discussion of high-level principles. Jackie?
Thank you. I'm really grateful to Joe for that intervention, because I found this very difficult, because all it said to me was there's a massive gap between aspiration and reality, and therefore it clearly lacked that executive attention so that it gets it to something we can actually deliver. So I don't really feel that I've got anything to add by discussing it any further, because it doesn't appear to have had that executive review.
Nikki?
The only sort of point of detail, if you like, I'd like to mention is that the priorities for communities. I think the people who we serve would be really disappointed to see nothing in that box. So I think that needs filling before we see it again.
Yeah. So Joe, and Joe, and then Richard.
So hopefully Richard's going to come in the same thing. It might just be useful to just very briefly touch on the work that's gone. So this has been a bottom-up exercise, but I wonder if Richard could just talk through how we've got to where we are at the moment, if not necessarily all the content.
So thanks, Joe. Thanks, everybody. I was just going to touch on that. I think I think where we've gotten to in terms of the divisional work is that last month we had an SLS, so a senior leadership forum with all of the divisions, and that each of the divisions presented where their plans were at a point in time. And I think subsequent to both Damien and Joe's points in this meeting, we now need to rework that post the changes to the budget, and also Joe's line by line conversation about where that goes in terms of workforce considerations. So in terms of us giving you assurance as to where the divisions are, these are very much their plans. They are plans at a point in time, and we have seen those as execs. So I think that would be the first point. I think the second point, which sort of picks up on some of Nikki's points around that last strategic aim box. What we're not saying is there will be no work on this in year. Obviously, Anita and the team are working on a load of priority outcomes with Daryl Gale and his public health team. We're working on the Core 20+5 in terms of those national priorities. And we also know that CQC will be having a range of key lines of inquiry, against which we will be assessed in terms of how we are delivering health inequalities. What I think we're trying to do, and it goes back to the debate we had at last month's seminar, is to say the key challenge this year will be the proliferation of asks on top of the additional core challenges that we will be set around money, around elective recovery, and around delivering for our staff as well. And what we've tried to do in these trust level priorities, which is what Joe is referring to as the summary document, is really just to say, when we come to what will be absolutely key in 22-23, these are the programs through which we will deliver these. These are the metrics through which we can give you the assurance that these programs are delivering, so as to demonstrate those high level trust priorities. It's not to say in certain areas there won't be some other work going on, but your point is a fair one, Nikki. The optics of something that says, actually, there's not a lot going on here, it wouldn't look good. So I think that's a very fair point, and I will go back and take that through. But I think there is the distinction between the two papers. On the one hand, you've got where the divisions are at, which is very detailed, very granular. And the other point, which is we as an organisation are saying, it's going to be a really tough year. Let's make sure we focus on all of those basics and get them right and show you how we're delivering against them.
Thanks, Richard. Okay, so I guess we've taken that as far as we can. Good luck with pulling all of this together, because I know it's a tricky balancing act between everything that needs to be done, and we look forward to seeing more in the immediate period ahead, particularly at F&I. Okay, thank you. Shall we move on to the quality account priorities? Vicky, it's a bit of a Vicky show today.
Apologies for that. I'm trying not to be outdone by Tara. Thanks, Chair. So very briefly, happy to take questions, but I'm asking the board to delegate authority for the approval of the account to the Quality and Safety Committee, albeit the board will have seen the account and the long list, short list, and the final three domains that have been put forward, and that was involving stakeholders and colleagues. So that is the ask, and we have our three priorities covering effectiveness, safety, and patient experience, and the nominated senior responsible officers for that will be myself and Richard and our Chief Medical Officer. But happy if there's any concerns or questions.
Anything anybody wants to raise? Jackie.
I'm sure there's an answer to this, but I don't really understand why the medical director would lead on nutrition and hydration, which seems to me a very ward-based or nursing-based activity. But I'm sure you can give me an answer, Vicky rather, not Nikki.
So I wouldn't agree entirely with that, and actually you might be surprised to know that the chair of our nutrition group is a consultant physician. So although I would absolutely agree that nursing takes the lead on a number of things, certainly in inpatient areas, I think it's important that it isn't solely nursing that takes the lead on the quality agenda. So there's very good reason as to why I felt it important that as an exec team that we share the responsibility and the oversight for that. So that's the simple answer, Jackie.
Right, so we'll see on the if the outputs and the outcomes don't match, then it's the medical director that gets it.
No, not at all, not at all. As always, it's about working together. And actually, I think it's really helpful because, you know, our doctor colleagues bring very different points of view. So I'm keen that it isn't just seen through the lens of nursing, although we would clearly do a great job, but so will our medical director.
Good answer, Vicky. And David's keeping diplomatically quiet.
Well, it will of course fall to my successor, so I feel it's
yeah, good point.
Not fair for me to comment, really.
Excellent.
Who I will work closely with, clearly.
Okay, good stuff. Good stuff. Okay, well, we're now doing well. So that moves us on to our maternity overview. I saw that Brenda has been with us.
Can I just briefly introduce Brenda, who the board will know well, and the discussion that we have had at every board and every board seminar. So this is the first of the new style maternity reports, and it hopefully provides an overview and assurance that the Trust is delivering safe and high quality services. Brenda and I are very happy to take feedback on the report, and going forward we want it to be helpful and useful. So do let us know if there's different or other things that you would want in there. But I'm going to hand over to Brenda, who will take you through highlights and headlines, and then we're both very happy if there's any questions at the end. Thanks, Brenda.
Thank you, Vicky and Chair. So there are 6 domains that we're going to be reviewing through the perinatal mortality review tool, and that is on a quarterly basis. So this report's on a quarterly basis. The 6 domains are the perinatal quality, surveillance, national ambition, operational delivery, Ockenden update, maternity workforce, voice of the user, and team or staff feedback. So the key points for Q4 are in the main maternity staffing and workforce. So to say that we've completed a workforce review using the Birth Rate Plus approved tool, which is consistent with NICE safer staffing, and that was completed in February 22. On the whole, ESHT meet the staffing requirements, but it was a recommendation that we uplift to meet additional training needs as discussed from 21% to 26.4%, and this has been approved by the Trust. Once recruited to, and we meet safer staffing, so we have got a bit of work to do. This will allow us to continue rollout of the long-term plan of maternity transformation and continuity of carer. And currently the dates suggest that we should have this in place by the 31st of March 2024, but these are likely to change in line with Ockenden and the need to review continuity of carer and ensure that we have safe staffing. So the plan is that 75% of women and birthing people should be booked onto the continuity of care pathways by March 2025. ESHT currently have 28.4%. The target was 35%. However, we're maintaining safe services, and we have a focus on equity and equality. Further rollout is detailed in ESHT's full service rollout plan, and this paper is available for review in the private part of the Trust Board. Concern remains regarding full rollout, and so part of ESHT plan is to ensure that we have full training for staff who aren't used to working in certain areas. Support packages for staff will continue, that we have equipment and also to ensure that we have community venues for the staff to work from. We expect that training will commence in September with further rollout of the next 2 teams around Q4 in 2023. We've had significant staffing issues over the past 12 months, as you're all aware, and this has been mainly due to sickness, short and long term, and maternity leave. We've had escalation plans in place, and these are now resolving, and we rearrange services to support the ESHT site. However, this we've now reopened Eastbourne Maternity Unit, and the intrapartum part of the continuity of carer teams is now back in place. A full staffing paper is available for the private board part of the trust board, and this is required by CNST, the clinical negligence scheme, and we will provide this 6 monthly. With regards to investigations and the Health Services Investigation Branch, HSIB, we made 3 referrals in 22 so far, 1 in January and 2 in February. Two did not meet the criteria. However, there are internal reviews underway, and very sadly, 1 intrapartum stillbirth occurred, and immediate actions were implemented. We did receive a letter of concern from HSIB, and ESHT has responded to that with all the actions taken, and a final report from HSIB is expected in August 22. I did meet with HSIB last week, and our LMNS and Trust are not outliers with regards to referrals or themes. There is going to be a thematic paper from HSIB, and that is due imminently for from the national team. Between May 21 and 22, sadly, we had 3 stillbirths. Our numbers are small. There's a national review yearly through the Embrace, which is Mothers and Babies Reducing the Risk through Audits and Confidential Inquiries, and the last report was published in 2020. ESHT have reviewed our stillbirths. We have found no trends. The LMNS, we've had a discussion as well as an LMNS, and we're obtaining data from across our patch, and we're going to carry out a thematic review within the LMNS as well. One of our areas of concern is smoking in pregnancy. It's a key risk factor, and significant work is in progress within our maternity service to reduce smoking in pregnancy. Local rates and booking and delivery are higher than the national average. With regards to Ockenden update, we have evidence of good progress against all 7 immediate and essential actions, and this is in a sustainable way. And we've completed a mapping exercise against the final 15 immediate and essential actions, and this will be discussed at a future board meeting. So with regards to the service user voice, we've had mixed feedback. We have clear action plans which will address some issues, and we're working closely with the Maternity Voices Partnership to co-design or review systems such as the induction of labour pathway and the caesarean section pathway. Finally, to celebrate, ESHT is we're the first special care baby unit in the country to achieve the Bliss accreditation for consistent high quality family centred care, and my thanks to all our staff for their hard work in this. With regards to positive feedback, we've had positive feedback from new staff starting to say how friendly our services are, and some staff who had left our trust to work in other hospitals have now returned. We've got an excellent preceptorship programme, and all of our student midwives are applying for posts in our trust this year, and that's around 13 staff. We've got 15 high quality applications to interview in the next week or so, and if successful, this will bring us to our full complement of staff, which would be around October, November time because of staff getting their pins. Thank you, Chair. Any questions?
Thank you, Brenda. That's I'm glad you saved that really good stuff to the end. That was really encouraging to hear. Fantastic. So all of the student midwives are going to apply.
Yes, which is great news.
Well, that's fantastic, isn't it? So we must be doing quite a lot right, as well as there are things that we want to do even better. So that's a good place to be. Amanda.
Thank you, Brenda, and everybody. I can see you've put a huge amount of work into this since our board seminar, Brenda. So thank you for doing that. It feels like a step in the right direction. I think what I think is still something that we need to work on, which is that very last bit that you were talking about, we should be really ambitious for our services, and indeed there is a lot to be ambitious about. Otherwise, our midwives, student midwives, wouldn't want to join us. And I was just thinking about the Maternity and Voices Partnership workshop that I attended. Was it a couple of weeks ago? I can't remember when it was,
Yeah.
which was, there was so much richness there in terms of what mothers feel and want from our services. I just wondered if there was another way of building our requirements, the statutory requirements of reporting, which you have done in this report, and telling our ambitious story for maternity services for ESHT, because I think there's a little bit of a missing ingredient for me, which is actually what are the things that we're really chasing after for women? How will we know that we've got there? On top of what we need to do, which is these very, very detailed, very specific requirements as per Ockenden perinatal surveillance tool. So it's that ambition that I think that we were talking about at the seminar, that there's something to build into the picture. So is that something on your mind, Brenda, or how?
Yes, absolutely, Amanda. This was the first report, and I am definitely going to add a lot more around what we're doing. And just to say, it's been tricky, hasn't it, for the last year or so, because we've had to maintain safe services, and that's been our focus. And now it feels like there's light, and we're just about to start some really great work within the department.
So I think that's the important thing, that the whole picture of our maternity services the board should have oversight of, and then we can use this kind of data to track through progress on that. And as the NED safety champion, I do know, and I do have insight into some of the other issues that we talk about on a regular basis. It's how we illuminate that to the board that reflects our ambitions and the areas that we still need to work on.
Sure.
But thank you. I really recognise the hard work that you have done in pulling this together. It's a step in the right direction, but I think if we go back to that seminar, there's the richer picture as well.
I'm working and building on this report every quarter, Amanda, definitely.
Thank you, Amanda. Any other questions for Brenda or indeed Vicky? No, great. Thanks very much, Brenda, and thanks for all the continued hard work. Much appreciated.
Thank you.
So, agenda item 13, Steve, and the Ofsted inspection report, first steps. I think the official opening of first steps is a couple of weeks away. Is it, Steve?
Yeah, I mean, it's been open for some time now, but or a number of months, but because of the challenges that we've been speaking about throughout the rest of the report, we've held off a summer outdoor opening, or celebration of the opening, should I say. I think the biggest celebration we can give to it actually is the excuse me, the Ofsted report, which came just a very small number of weeks after it opened. It was a good report. There were only two recommendations that were identified. One of them was to do with noise levels, and interestingly enough, quite a lot of the feedback there was around mask wearing, which we've touched on again today, and I think that sort of resolves to a degree. The other one was around some staff development. We've submitted plans against both of those, but the papers are just here for the board to note. I'm very proud of the work that Jackie Fuller and the team have done. Jackie's personal mission, almost, to get to get the new nursery to the position it has, which has been stunning, and the work that the entire team have done to get it up to speed to be able to get a good Ofsted report so quickly.
Thank you, Steve. Yeah, very good stuff. Questions for Steve? No. Thanks everybody, and Steve, would you pass on our thanks to Jackie for all that she's done around this?
I will.
Item 14, use of the trust seal is quite easy. We haven't done so that's relatively straightforward. So that takes us to questions from members of the public. A couple of our most enthusiastic contributors are not with us this time, and we've had nothing in writing. We usually have some detailed and interesting questions from one of our regular contributors, but we've not had that. So Alison, that leaves you as the only member of the public. So if you did have anything you wanted to ask us, now is the time.
Steve, I think Alison may have dialed out.
I think I'm not sure whether to be offended or not. Well, so that makes life very easy then. So we can call the meeting to a close. The next public board meeting is on Tuesday, the 9th of August, and it's going to be face-to-face in the St. Mary's boardroom, subject to infection rates and who knows, but all things being equal, we'll be at the St. Mary's boardroom. So no turning up in pajama bottoms, and proper full Sunday best. Good stuff. So we're on for 1 o'clock. We can't start sooner because we've got visitors joining us, so a chance to grab some lunch, unless there's anything urgent anybody wants to raise before we just wrap up. Okay, grab a break. See you at 1 o'clock.